I'd like to thank Simon and Beverly for inviting me here to share my views on incidental VTE. I also like to thank AJ, who's left, who really set the scene very well. I will be replicating some of the evidence presented, which is much more relevant to the incidental VTEs that happen to patients with cancer. And I also like to thank Simon, who's talked about his swamp again, and I will show you my best backstroke of how you'll get out of the sometimes lack of evidence of how you treat some of these patients. Now, the first thing I'm going to say is that the talk talks about incidental VTE. I will present some of the impact on patients' lives from incidental VTE as a whole and some of the epidemiology. But the real, if you want, slippery element of the VTE process that has slipped into cancer over the last 10 to 14 years is the increase in a entity called incidental pulmonary embolism. And that can be quite difficult to, if you want, define exactly in terms of its potential prognosis, and can also be quite difficult to get consensus on how you should be treating these patients. I'm going to do my best by the end of this talk to have some sort of stroke for us to try and get out of the swamp. So, without much more ado, white one, okay. So the first thing is that AJ has already covered most of this. It is a serious problem, as you very well know. This is VTE overall, not only in cancer patients. It is pretty lethal. But the things that I want to highlight here is that when you have a DVT at diagnosis, about 50% of those patients will be harboring a pulmonary embolism. And about 33 to 40% of those PEs will be symptomatic. Therefore, the others will be asymptomatic. And about 70% of symptomatic PE will have a leg DVT. Some will be symptomatic and missed, but some will not be symptomatic. And that immediately tells us that we already know that we have had these entities of asymptomatic, if you want, or non-diagnosed clots before the era of the high-resolution CT scan, which has changed things recently. I also thought it useful for us to go back into history a little bit and see what was happening in the days before the treatment of pulmonary embolism was either effective or recommended. The first thing to tell you is that about 10% of symptomatic PE are fatal within 1 hour. We very often find them on post-mortem. We don't make the diagnosis before they die. However, of interest is that if you don't treat them, and this is data from, you can't see, can you see it down there? From about 1950s, 1960s, if you don't treat them, 25% will die within those first 3 months, and about 50% will have a recurrence. That's about 34 patients who were randomized in a trial published in The Lancet back in the 1960s who did not get treated. Patients who got treated even for 14 days with a vitamin K analog and heparin actually had only one mortality one lethal event in the follow-up. Why am I saying all this? Because the end game of incidental pulmonary embolism is, are there any patients who may not need treatment? Are there any patients who actually can just observe? And I'll try and filter that question right down to the end and find out where the latest ACCP guidance is going. AJ has already shown you two major databases, the Sorensen database and very many others. I'm just showing you that even a more recent database, 2014, shows exactly the same thing. This is the Thrombosis database, so a captured population of patients. It's an epidemiological study, shows that if you have a cancer and your thrombosis, it's bad to have a cancer by itself compared to normal patients followed up over 13 years. But if you have a cancer, you clearly have got a greater chance of dying over that follow-up period. But if you have a cancer and a deep vein thrombosis, it's really even worse than that. And this is our own data from a randomized trial looking from a different setting one of the things that separated pancreatic cancer patients on doing badly in a bad cancer was the patient with pancreatic cancer and DVT or VTE, or PE, over a period of, I don't know, 9 months, they don't live very long, have got a mortality which is higher if they've got a DVT at the same time or a PE compared to the population of patients who still do very badly, as you can see there, but it separates even in this really seriously ill population of advanced pancreatic cancer patients. So, how do we define incidental? Incidental is either unsuspected, okay, but it is not silent and not asymptomatic. We need to pass these words into extinction. No clinical suspicion of the PE beforehand does not mean the patient does not have symptoms. Diagnosed on imaging done for other reasons, and the imaging protocols are non-angiography protocols, but some of the CT scanners we have nowadays are 64 collimator scanners, which have got spectacular ability to opacify the vasculature of the lungs, yeah, and pick it up at the time of pacification. And it has become a particular problem in cancer patients because they get frequent and repetitive scanning. Why is that? Well, first of all, I remember, because I'm pretty long in the tooth, when we used to manage patients with colon cancer with a chest x-ray, an ultrasound of the liver, and a colonography and a CA. And that was the follow-up. Nowadays, it's become whole body CT scan. Everything that happens to cancer patients, whole body CT scan. So the lungs are scanned in almost every patient, mostly because this has been driven by trials, where I do melanoma as well, and we thought that DTIC had some responses in the skin, but once we started scanning the patients throughout, DTIC's response rates fell from the 70s, where it was around 20%, 18%, down to 7%. And that is why patients with cancer get all these fantastic images, and frequently, every 12 weeks, every 8 weeks if you're on a trial. And what the other problem is that since 2004, around 2004, brand new fast scanners, high resolution scanners, our current standard is 1 millimeter CT slice thickness. And that I think is in most cancer centers right now. And they are picking up what AJ said earlier, clots. And the question mark that comes is how significant are all these clots? And it did affect our trial because our trial straddled the period where the CT scanners came. The trial started in 2003, and by 2006 we had to put a major amendment in because we had this bunch of patients at around 80 to 90 days appearing with pulmonary emboli on their staging or response scans, okay? Compared to the other emboli we saw in this trial, which were the regular when you see pancreatic cancer, just like AJ said earlier, the mass of them happening early in their disease and preventing them for these patients, but when the prevention stopped, the clots start happening again. And that was the reason why we had to incorporate incidental pulmonary embolism suddenly, which was a non-entity on the previous scanners, to accommodate our endpoint. So what is incidental pulmonary embolism? It's clinically undiagnosed. You don't know the patient has it. That's why it's incidental. But it could be really silent or clinical symptoms misattributed, false silent. And just because now you've got these better scanners and scan them all the time, you're starting to pick it up. The problem of recognition is what has been very difficult to filter through the community. People have felt that, it's just an incidental pulmonary embolism, it's going to be asymptomatic, should we treat it? Well, the recognition gaps are really between, is it clinically evident or radiologically evident? And that's very different. You've got to go back and find out if it is clinically evident, because that will help your management. Is it clinically suspected versus clinically unsuspected, but clinically apparent? Is it clinically silent? It's easier to determine in a non-cancer setting. So it's fine when you've got somebody who came in for a chest infection, did a CT scan, and found a very small subsegmental pulmonary embolism. But it's even easier if you've got somebody who came in for something totally different, accident or whatever, and you find a pulmonary embolism. But it's very, very difficult in a cancer patient who's got multiple metastases, pleural effusions, lung cancer particularly is a difficult one, and they also have got anemia and all the other things happen to chemotherapy, to say that that's clinically silent clot. How do you do that? And most data derived from trials with active ascertainment go back to the 80s and the 90s, and that's why we know the data showed you earlier and what AJ said earlier. Patients would get a pulmonary embolism and then they go and have an ultrasound of the legs and find it there. And that's why the figures we have come from actively looking for the VTE, but also from a technique called VQ scan, which you all know, but which has now become rather not very commonly used. So how common is incidental? This was one of the first series that came literally out of our trial, out of our trust, which showed that about 2.6% of all helical scans, that's what we call them then, high-res scans or 64 collimator scans, will have a incidental pulmonary embolism on them. But that was sequential scans. Some of those patients were getting second and third and fourth scans. So it doesn't give you the instance per patient. But the subsequent paper here from Cronin et al. Tells you that about 6.3% of cancer patients will have an unsuspected VTE on imaging. It'll be a pulmonary embolism. It could be a clot sitting in one of the visceral veins. It could be both a P and a DVT. In Hull, we service as a cancer center directly for chemotherapy about 500,000 people. And we see about 53 to 57 incidental pulmonary emboli a year. So that is, and that's reproducible because we have been collecting the data now for about 10 years, since 8 years. And this is some data that we've published back 2-3 years ago on our first 155 patients. And you can see the first thing is that the majority of these are actually proximal. So they may be incidental, but they are proximal. Okay? But you do have a group, and I will be talking about this particular group at the end of my talk because it is where the controversy lies, of subsegmental, purely subsegmental only pulmonary embolism. That's about 9%. When it comes to symptoms, we do ask patients 2 questions because we are prospectively collecting the data, which has allowed us to separate patients out into high-risk groups. Have you got any new symptoms? Patients understand that very well because they're geared to understand new symptoms and come straight into oncology because it's usually chemotherapy related or septicemia or whatever. But we asked a general question, have you got any new symptoms? And the second question, have you got any symptoms that have got worse? If the answer is no to both of these, and some patients are purely silent, adjuvant colorectal cancer patient, extremely fit, just finished chemotherapy, biking, I don't know, the cyclosportif G, he's got a pulmonary embolism and he's totally asymptomatic. But that will be the rare one. The group of patients who do not have symptoms, you need to actively identify them because cancer is a soup of symptoms, unfortunately. So what do you see? They will have dyspnea. And we find that in 48% of the patients. Fatigue is very, very common. That was highlighted by O'Connell et al. That this is a very common symptom. Chest pain. So the actual symptoms that you would associate with a pulmonary embolism are there in these patients. But the 2 main things to identify is that you've got around 60% of the patients will have new or worsening symptoms fairly recently. But around 40% won't. The interesting thing to say is because we're collecting also cardiovascular parameters, is that they do not feature very highly. So although the PESI score is a score that apparently we started using because it should give you a high resolution in terms of the patients who are at high risk of early death from cardiovascular compromise, we find that very rarely in these patients. There's many other things happening to them, but we do not find in this ambulant population is really, if you want, pre-lethal or extremely compromising to the cardiovascular system. Pulmonary emboli so common in this group of patients. But what's the prognostic significance of these things? Well, I go down to whole VTE. So this is finding any VTE in these patients, whether it is incidental or symptomatic. Okay, it is got the same prognostic significance compared to somebody who's got cancer but no VTE. So there is a significant impact. And it's not different whether the VTE is incidental or symptomatic. When it comes to pulmonary embolism per se, you'll see here that whether the patient has got an incidental pulmonary embolism or a symptomatic pulmonary embolism, the outcomes in terms of survivorship are exactly the same when you've got cancer as an underlying problem. Similarly here, this is a study where it looks at a normal case control or matched control, so 137 matched patients, okay, who do not have UPE but have got cancer, compared to a group of patients who've got a suspected PEP, about 70%. This is the O'Connell data, some of the first data that came out in JCO back in 2006. And clearly there's an impact on survivorship for these patients, very similar to what AJ presented in the first part of this morning. So we're coming down to the question now, should we be treating all these patients, not to treat? Well, it's fairly simple if you look at IPE as a whole group. Untreated IPE is more lethal, and there is a 900 patient cohort sub-analysis which happens to have a group of patients who were not treated. Now, when you're looking at retrospective data, unfortunately, there's bias. Maybe those patients were not treated because they were end of life. Maybe they were not treated because they had a bleed. There may be other reasons. But some patients, I'll present the data in the second study, were at clinician's discretion. And we can see that the mortality at 6 months is higher in the untreated population compared to the ones that are treated either with a VKA or with low molecular heparin. The second study is only in lung cancer patients, and those patients can get compromised, respiratory compromise, even with small PEs. 113 IPEs were identified, and half of these were left to be treated at clinician's discretion. And they treated some, but there was a good bunch of patients who were not treated. And you can see the mortality or the median survival of the patients who were treated compared to the patients who were not treated was very highly significant. Again, retrospective data in a particularly difficult cancer where just can go wrong pretty quickly. But at least according to these investigators, they were matched for stage, performance status, and treatment response. So the ACCP guidelines are fairly clear since 2011 and remain rather clear in 2016 as well, although I'll be going into that in the next 10 minutes. Would recommend a grade 2B that you should be giving comparable treatment to patients with unfortunate wording, which came from the way they looked at the data before, asymptomatic versus symptomatic. I would say the wording is unfortunate. It should be incidental versus symptomatic or diagnosed upon suspicion. So where is the controversy? And the controversy does lie with this entity called subsegmental pulmonary embolism. Outside cancer, it is thought to be possibly in some patients a non-entity, a total artifact of a very good test. And there's some good evidence to say that that's the case. So what is a subsegmental? It's really a very small clot that you find when you scan a patient with a high-resolution CT scanner for breathlessness. And as you can see, this patient probably has got cancer, has got many other reasons to have breathlessness other than that clot over there. But I'll come to symptoms in a little bit. So where does the controversy lie? Well, first of all, much of our data was derived from when we had VQ scans. And we now know from a randomized trial that VQ scans would insert SSPEs and some segmental Ps into what are low probability scans for a pulmonary embolism. So they were missed. But when you did a CTPA on these patients, you picked up more of these clots. But there was no obvious adverse outcome in the arm which had VQ scans, or the patient had VQ scans only, and they'd been classified as low probability. Anecdotally, untreated SSPE in the non-cancer setting does not seem to have adverse outcomes. There's a reference over there where they haven't treated patients and nothing has happened. Epidemiological data, which are very interesting, show that we've got better at diagnosing our pulmonary emboli, but the mortality of this diagnosis, this is non-cancer data, has remained roughly the same. And I add that this is where we started scanning patients with spiral CT scans, somewhere around here, okay? So this is just going up and up and up, just like AJ said earlier, and is it significant? Maybe for the non-cancer population of patients it isn't, and currently there is a very big trial that Mark Carey is running out of Ottawa, which should conclude recruitment this year of 300 patients where he has got an SSPE, patients are symptomatic, does a Doppler of the legs, and just follows them up. And it'll be very interesting to see what those data will tell us. And those investigators indicate that this is the result of just a very, very good scan that just overdiagnosis a non-problematic entity. If it was a diagnostic effect that was diagnosing a problematic entity that we're picking up early, we should see fatality go down. But actually, we've seen an increase in incidence, but no change in fatality. So that's the point that they are making. So how common is SSPE now? I'm drilling down now to this particular entity. It's around 9% of patients with cancer. Okay, this is a series from 0% here to 24%, the O'Connell data presented earlier, 9% in our group, and once you do so like this 670 patients, around 9%. Okay, and these are the references. Does it have a survival impact in cancer? This is a very interesting study. Again, those same 70 patients that O'Connell has presented against their controls. They identified a small subgroup of subsegmentals, the 24% I said earlier, and they find that they actually live exactly the same as the case-matched control, so no impact compared to the rest of the more proximal pulmonary emboli. Now, we've looked at our own data, and that's now an update on the 155. This is 248 patients that George Bozas has analyzed, and we hope to publish this, where we have also looked at our subsegmentals versus others. And as you can see, the subsegmentals and the others are literally overlapping. So we can't see in our group of patients any difference in outcome, whether it's subsegmental or not. And I'm going to sit on this paper slightly more because I think this is the only paper that defines what I do in practice until Mark Carrier comes up and tells us something different. Now, this paper was published by Dan Exter a couple of years back in Blood. It's a large pool of 2 studies, 3,700 patients who had a suspected clot. So they were all symptomatic. And that's why I'm coming back to the fact that if you want to manage these patients, don't forget the symptoms. Try to identify whether they really have symptoms or not. These were non-cancer patients, but there was a significant cohort of patients in there who had cancer. Okay? So these symptomatic patients had all the usual well scores and everything, and then they had their CTPAs, proper CTPAs. And he identified 16% of these patients, 116 cases, had an SSPE only. And then they looked at the rest of it, and they found that the 3-month risk of recurrence was exactly the same, which is surprising, because there's a lot of data showing that the recurrence of SSPEs in the general population is extremely low. And the mortality was not significantly different. SSPEs were at an increased risk of VTE during follow-up. As you can see, the hazard ratio made them worse than if you had a symptomatic proximal pulmonary embolism, which was, again, surprising. But then the reposts happen in the literature, so these are all letters I'm going to go through, where the same patients that I showed you earlier, those 137 and 70 by O'Connell, were filleted according to symptoms. And they said their symptomatic patients do really much, much worse than their asymptomatic patients. And this is the data that we have generated now from those 248 patients, okay, which now separates them into 3 nice groups. And the most significant discriminating factors are new or worsening symptoms and performance status, which again is a measure of how symptomatic a patient is and how his ADLs are affected. And we have analyzed everything else, D-dimers, SSPs, blah, blah, blah. We have found nothing that stands out other than 1 or 2 blood tests, very little like creatinine and white count, but they do not impact once you analyze data for these things. So we had a handle on that data coming through because we had a feel for it when we analyzed the first 150 patients. So we decided with Simon and some others to do a survey and see how are clinicians out there who have cancer patients coming through their door treating the SSPE? It's the only survey that was only cancer. We gave 2 scenarios. They were both colorectal cancer. One was adjuvant setting, and the other was metastatic setting, but with response of the cancer at the CT scan time. The data I'm going to show you here, because it's got a lot of data, that paper, is how did symptoms impact on the decision-making of 3 separate groups of clinicians: oncologists, lung clinicians, and palliative care physicians. And I expected to see some, if you want, change or some difference in management from the pulmonary clinicians, because they read the ACCP guidance. They did not read the ASCO guidance that we read as clinicians. So this is our data. We had 154 physicians. In the adjuvant setting, the oncologists will, in an asymptomatic SSPE, will treat the vast majority. While you can see this is much more nuanced with the other 2 groups. So chest physicians and palliative care physicians. Why is that? Well, I guess an oncologist just about got a patient through his adjuvant chemotherapy. He's happy to have him alive, and suddenly sees a clot there, and the last thing he wants for this patient to drop dead from, and he probably doesn't know the literature either. In the adjuvant setting, it's interesting. Several physicians who would initiate anticoagulation immediately in the presence of new onset dyspnea and fatigue, they all go up to 97%. And I found that extremely interesting, because that has to be, either they'd read the paper that came out at the same time we did the survey, which is impossible, okay? They knew our data, which is impossible, or there's something about patients having symptoms that worries you enough to say, well, even if it's an SSPE, I'll treat it. I think that's correct. And we did a letter answering to Winner saying that we still think that the practice should remain as it is until we have better data. And the metastatic setting, there was no difference before, there's no difference here. So metastatic patients are treated fairly appropriately according to what the ACCP guidance from 2016 offer us. So I'm closing now with where we are as we speak right now. In patients with subsegmental PE, no involvement of more proximal pulmonary arteries, and no proximal DVT. So you've done a bilateral Doppler in those patients in their legs, and you haven't seen anything. Low risk for recurrent VTE. See text. Text is down here. They favor clinical surveillance over anticoagulation. However, if they've got text, which means if they've got an active cancer, particularly if it's metastatic or being treated with chemotherapy, then they favor anticoagulation over surveillance. But they favor it. And that is something that you need to keep in mind. For example, if I have a colorectal cancer patient, finished 6 months of chemotherapy, no lines in them, no cancer on the repeat CT scan, very, very well, totally asymptomatic, and there's an SSPE on the scan before I send him back to surgeons, I'll probably monitor him for another 3 months and then send him back to the surgeons. But I probably wouldn't start anticoagulation, and I'm well within my rights. So it's fully defendable. So in conclusion, please avoid terms like asymptomatic or silent when making the radiological diagnosis. Use incidental or unsuspected. However, symptomatic versus non-symptomatic characterization is a rationale that you need for further management, at least as the data stands right now. In the presence of a cancer diagnosis, treatment, etc., guidelines recommend anticoagulation for an IPE. Some evidence exists for worse outcomes, which I showed you. However, for an SSPE, in the presence of active cancer or cancer treatment ongoing as provoking factors, you should really anticoagulate the patient. But if you can establish that there's a true absence of symptoms, ask the right questions, or the patient is really bona fide asymptomatic totally from his cancer and the PE. Non-active cancer or treatment more than 6 months, one can consider clinical surveillance, okay? In the presence of new symptoms, however, consider anticoagulation. And I still think that I would follow the Dan Exeter data there. So, how would you monitor them over 3 months? That's lovely. They give you the guidance, but there's absolutely nothing in the literature to tell you what to do over those 3 months. Do you bring them in every day? Do you get your nurse to call them once a week? Or do you wait to do what there is a little line there, patients told to return for reevaluation if symptoms persist or worsen? And that's what exists in the ACCP guidance. So I'll leave it there, and I'm very happy to take any question. Thank you.